Good morning, everyone. This is Lynn Sutphin, Public Information Officer here at MDHHS. We'll get started here in a few minutes. I need to grant individuals video or permission to videotape. So if you wish to videotape, I need you to raise your hands, please, and I can do that. Okay, one last time before we get started. Anybody who wishes to videotape, I need to grant you permission, so please raise your hand. Okay, we will be recording this presentation, so everybody's aware of that as well, and posting it later. Once again, my name is Lynn Sutphin. I'm the Public Information Officer here at the Michigan Department of Health and Human Services, and we are offering once again another Michigan COVID response data and modeling update with Dr. Sarah Line-Callow from the department. We will have some opportunities for questions at the end, although it might be very short. It sounds like Sarah's got some great information to share today, but we will do our best. Sarah, I'm going to let you take it away.
Thank you, and Happy New Year. Happy 2021 to everyone on this call. Let's move to the next slide, please. So Michigan is holding relatively steady in terms of its position with other states and jurisdictions regarding our case numbers and mortality numbers. Our case rates and coronavirus-like illness rates have both been decreasing. However, it appears that that decrease appears to be slowing. Most recent data, our case rates are 237 cases per million people. Percent positivity has begun to increase in recent days, and we're currently at 9.6% of tests coming back positive. 13.1% of available inpatient beds are being used to treat patients with COVID-19, which has been coming down. During the week of December 20th to December 26th, there were 572 deaths due to COVID-19. That number is down 181 from the week prior. Our daily diagnostic tests did drop during this holiday season. We're down to about 33,000 tests per day. And we definitely need to get those numbers up so that we can understand what is happening with the spread of the epidemic in the state. In terms of a vaccine update, you're getting some numbers ahead of our dashboard update here. More than 520,000 doses have been shipped to providers in the state of Michigan to date. And we have more than 152,000 doses that have been reported back to us as administered by providers. And we're going to spend a little bit of time today on talking about the new variant, B117. We have not yet detected it in Michigan. I don't think we would be surprised if it was here already. And we expect that it will have or could have significant impacts on the spread of the disease in the state. Next slide, please. So many thanks to Michigan Medicine and University of Michigan School of Public Health. They contribute a lot of material to these slides, and I want to recognize that. This comparison across states, we're seeing that there are 33 states in the nation that had increasing one-week trends. That's up 8 states from last week. And there are 48 states with significant outbreaks going on over the past 2 weeks. Looking at the Midwest, Wisconsin is showing a slight decline in their hospitalizations, a slight rise in their cases. Indiana has stable hospitalizations and a slight drop in cases. Illinois is continuing to show a slow decline in hospitalizations, and their cases are fairly steady. Ohio has a slow decline in hospitalizations and a stable case rate. And Michigan, we're continuing to show a decline in hospitalizations, and we have a stable or perhaps a slight rise in our case numbers. Next slide, please. So thinking about COVID-19 spread, although our positivity has been declining, we reached a low of 8.2% on December 27th. We've recently increased to 9.6%. 4 MERC regions in the state remain below 10%, but I expect that will change in the coming week. The Upper Peninsula so far is the only region to see an increase in positivity over the previous week, and they're now up to almost 5%. Our cases continue to decline for 46 days. However, that decline has plateaued, and we're remaining vigilant. We're expecting a rebound in cases. We are seeing this decrease among most age groups, race, and ethnicity groups. In terms of outbreaks, the number of active outbreaks that were reported as being worked on by local public health is down 9% from the previous week, and the number of reported school outbreaks also decreased. It's down to 78 active outbreaks. Next slide, please. So let's look at the three of the indicators that we were focused on for understanding the epidemic. You can see that trend over time for these indicators. So positivity, as I mentioned, it reached a low of 8.2% around 12/27 and has been increasing, and we're now at 9.6 as our most recent 7-day average. You can find all these graphics and the data behind them on mysafestart.info. In terms of daily cases per million, we had reached 227 cases per million people on December 25th, but that has really plateaued. I can't really call that much of a decline anymore. And we're now at 237 cases on December 29th. It's important to understand that the data I'm presenting here are based on onset date, and we do some backfilling where it takes a little while for a case investigation to be conducted. So these numbers will shift, but right now what we're seeing is a plateau in our decline. In terms of daily hospitalizations, 12.6% of inpatient beds on the most recent day are being used to treat COVID-19 patients, and this is down from 19.6 on December 4th. Moving to the postage stamp, this is data that is presented for each of the MERC regions. A couple of highlights here. You can see that we had been seeing a decline in all MERC regions in terms of their case rates per day. Jackson County is over 300 cases per million per day, but everyone else is below 300. So it's a nice milestone to be below. Average percent positivity has been declining. Looking at that week by week in most MERC regions, with the exception of the Upper Peninsula. Unfortunately, when I look at the daily numbers for these percent positivities, I'm expecting that this decreasing trend will not maintain. In terms of tests per million, it would be very good to see if every MERC region had at least 4,000 tests per million people. And you can see that we, with the exception of the Jackson region, we did not meet that goal during the most recent week of data. You can also, one of the columns I'll also highlight here is you can see the percent of inpatient beds occupied by patients with COVID-19. And you can see the variability there. All areas are now below 20% for that indicator. Next slide, please. So this is giving you a picture of percent positivity by county. 23 of the 83 Michigan counties had positivity that was 10% or more in the last week, and that's a reduction of 5 over the prior week. Again, this is a 7-day average. Next slide, please. This is a graphic that provides the information on the number of cases that are reported out each day by the state of Michigan. This is the date that we became aware of the case, not necessarily the date that the person became ill or that they had a lab test. The number of weekly reported cases to public health has plateaued, or perhaps it may be on the increase there. Next slide, please. These are the number of cases, but in this part, they are plotted by the date of onset of symptoms. Cases have dropped for 6 weeks in a row, and the current daily case rate remains more than twice the rate from early October. Again, these are data that we're looking at from ending the beginning of the year. The early signs that I'm seeing looking at the data from this week, I'm suspecting that we're not going to see this continued decline. Next slide, please. So it's looking at the age-specific case rates. So the 30 to 49-year age group continues to have the highest case rates per million people. However, case rates have decreased for all age groups over the past 6 weeks here. Next slide, please. Our average daily new cases per million people by racial group is also showing that we're seeing decreases for all racial groups since the beginning of December. And then moving on to ethnicity, we can see that cases per million have decreased for, sorry, next slide, please. Apologize. For both cases who are considered to have Hispanic Latino ancestry and those who do not have that indication in their record. Next slide, please. So moving on to outbreak investigations. Just as a reminder, these are the number of outbreaks that local health reports to us that they are working on each week by the type of site where these events occur. The week of December 30th was a shorter week for some people in terms of the holiday. So I'll be interested to see how these numbers change in the coming week. But we did see a decline in the total number of active outbreaks. It's down 9% from the previous week. Following long-term care facilities, the greatest number of new outbreaks identified were in the manufacturing and construction fields, retail, office setting, and healthcare setting. Local health departments reported new outbreaks in all settings except agricultural food processing and outdoor community exposures. Next slide, please. In terms of school outbreaks, local health departments reported that they were tracking or working on 78 outbreaks associated with K through 12 schools. That number has declined since the previous week from 119 to 78, including reductions at the high school, middle, junior high, and pre-K elementary levels. Outbreaks that are associated solely with administrative staffs also did decline 1. You can also see the range of the number of cases in these outbreaks has also declined a bit. Next slide, please. So moving on to healthcare capacity and measures of COVID-19 severity. Our hospitalization and ICU utilization has been decreasing in the state. We can see this in the emergency department, the inpatient floors, and ICU. All regions in the state are now below 30% of adult ICU beds being occupied by COVID-19 patients. There are 4 regions that remain above 20%. Our mortality data has declined for the second consecutive week. It's important to understand that there can be delay in reported deaths due to the holiday break, so that this number may rise in the next few days. But right now we are reporting this as a decline. Next slide, please. So this graphic is depicting the number of, or the percentage of emergency department visits that are due to different syndromes. The purple line is showing you the percent of visits that are related to COVID-19 like illness or a diagnosis of COVID-19. You can see we'd had a nice decline in that number. Most recent 3 days seems to be fairly plateaued in that number. Next slide, please. This week, there are 2,379 inpatients being treated for COVID-19. This is down 6% from the previous week and down 40% from the December 1st peak. The rate of this decline is slower this week than it has been in the past few weeks. Next slide, please. This is looking at that same data for each of the preparedness regions in the state. Most regions are showing decreasing trends in their hospital census for COVID-19 this week over last. Regions 5 and 6 have had slight increases this week, but the absolute increases are relatively small. Next slide, please. This is looking at the COVID-19 census in our ICUs in the state. That census has declined 17% over the past week. All preparedness regions are showing this decline except Region 7. For the first time in many weeks, no regions in the state are having to use 30% of their ICU beds or more for COVID-19. Next slide, please. So looking at mortality, this is providing information on the number of deaths by date of death. Since last week, the number of deaths has declined. The current number of deaths is now 6.5 times the number that it was in early October. Next slide, please. These two graphics are giving you age-specific rates as well as the age-specific total number of deaths in the past 30 days. You can see the light blue line on the left-hand side is the rate for people the mortality rate for people 80 years or older. And that rate is definitely declining, as is the rate for 70, 79-year-olds. Other groups are experiencing decline, but not as sharp a drop. Next slide, please. We're also seeing declines in mortality for all racial groups. And next slide. As well as for people of Hispanic or Latino ethnicity, we're also seeing decline there. So moving on to public health capacity. Pardon me just a minute. Our testing volume has declined. We're down, the most recent day we had about 36,000 tests performed. 15.3% of all diagnostic tests are now antigen tests. So it's good that that rapid response information is getting out there. Testing by county ranges from 1,600 to 13,000 daily tests per million residents, including antigen tests. Compared to other states, Michigan has remained relatively steady in our testing levels. And we're performing more per capita testing than about half of all other states. Our case investigations did decline a bit over the holidays. The proportion of cases interviewed continues to show lower known source of infection, indicating that we're continuing to see community spread in Michigan. Among those cases interviewed, there continues to be a low proportion of people reporting that they were quarantining when they became symptomatic. And this is very concerning. We need people to be separated from others if they've been exposed to COVID-19, because it can be spread asymptomatically. And this will become even more important as the B117 variant enters the United States and may impact Michigan. Next slide, thank you. So this slide is depicting the number of daily diagnostic tests by message date. You can see we've had a decline during the holiday period and a recent resurgence there. We're at about 15% of antigen tests is that little blue line at the top of the stacked bar. Among antigen tests only, we have about a 4.7% positivity. Next slide. Looking at our position relative to other states in the nation, we're 5th for the number of daily PCR tests we perform. We're 20th in terms of the percent of the population tested. We're at about 2.5% of our population was tested in the last week. And our percent positivity, this is a little bit older data now, it's at 9.4%, but we're 10th in the nation. Moving on to public health investigation metrics. During the week of December 19th through December 25th, local health departments were referred more than 16,000, almost 17,000 cases for investigation. They were able to complete a case investigation during that time on 53% of those cases. Among those 9,000 people interviewed, 44% were able to identify a source of infection. It's up a little bit from the week prior, but only 28% of those cases reported isolating at time of symptom onset or quarantining at time of symptom onset. I'm sorry, I was reading the wrong numbers to you there. I do apologize. Usually I have my most recent graphic on the left. I am so sorry. Let me do that again. Our case report information from 12/20 to January 4th is what I should have been referring you to. So the number of cases that were referred to local health during that holiday week had declined to more than 14,000 cases. 44% of those cases were investigated during that week. Of those cases that were investigated, 43% had identified a known source of infection and 27% were quarantining at time of symptom onset. Next slide, please. So I want to go through and talk about our COVID-19 vaccine dashboard. I want to thank you for the questions that we've received on the dashboard. It's very important that we're getting clear information out as rapidly as possible. I'm very proud of the team that has put this dashboard together, and we are continuing to make improvements in response to questions and to seek to get more data and more enhancements up on this dashboard. I wanted to walk you through some of the pages here, not only to provide some of the information on the dashboard, but also to highlight some of the things that I think we can strengthen the wording on, or it may be confusing. So this first screenshot here is showing you the COVID-19 vaccine distribution information. And what we mean when we say a vaccine has been distributed is that it has been sent from the distributor, either from Pfizer or McKesson. It has been sent out to the provider who put the order in. And the dates in this are based on the date that the vaccine was sent by the distributor. It's not necessarily the date that the healthcare provider received the vaccine and could actually open the box. Something else about this dashboard that we're going to be working with the wording on it to try and make this clearer. But if you go to this dashboard page and you click on local health department and you select one of those local health departments, the number that comes up is the number of doses that were distributed to someone in that jurisdiction, to some provider in that jurisdiction. It is not the number of doses that go to specifically the local health department as a provider. So I think the way we have that worded there is confusing, and we're working on improving that. But it's meant to be on this page. If you click on local health department, it's telling you how many doses have gone to any providers that are located within that jurisdiction, not that it has gone to the health department itself for distribution. So we've had more than 520,000 vaccines first doses distributed. That includes more than 411,000 Pfizer first doses that have been sent to hospitals and local health departments, and more than 108,000 Moderna first doses. And Moderna has been sent to hospitals, local health departments, federally qualified health clinics, and a couple of tribal health centers. Next slide, please. I know we've gotten a lot of questions around the Federal Pharmacy Partnership Program for long-term care. We put our hand up for both Phase A and Phase B of the long-term care program. Based on the estimates of the number of staff and residents associated with long-term care facilities, MDHHS has or is about to transfer over 300,000 first doses of Moderna to the federal program over a 5-week period. These doses come off of Michigan's allocation and get held, I'm saying into a bank here, that the federal program can then pull from to distribute vaccine to CVS and Walgreens as they hold clinics at long-term care facilities. So the transfers that we've made, there was 65,300 doses that were transferred the week of December 20th. There were 60,400 doses transferred the week of December 27th. And then the weeks of January 3rd, 10th, and 17th, we either have transferred or are holding for transfer 60,400 doses each of those weeks. Thus far, 185,100 doses have been transferred to the federal program. So our dashboard is being updated to include information on these transferred doses. This information doesn't flow into the MICR, so we are needing to pull two different data systems together. But we're doing our best to get some changes onto our dashboard to make this clear so that you can have a fuller picture of how many doses Michigan's allocation, total allocation is. Next slide, please. So going back to our dashboard, I want to explain what we mean when we say COVID vaccine doses administered. This I think of as shots in arms or doses in arms. So it's a vaccine was actually delivered into a human being. These doses on the dashboard are reported by where the person who received the vaccine lives. Between December 14th and January 6th, so this is new information. You can see my screenshot isn't updated yet, but we had reported to us 152,511 vaccines having been administered. Providers have 24 hours to provide this information to us. The majority of these doses have been administered by hospitals, local health departments, and federal long-term care pharmacy partnership. Next slide, please. I've had a number of people ask me questions about, well, I've looked at the number of doses that were distributed to a county, and then I've looked at the number of doses that were administered, and I want to put those two numbers together to create a percent administered within a jurisdiction. Because the doses administered are plotted based on where a patient lives, because we're interested in determining, what percentage of residents have been vaccinated, and the doses distributed are plotted by where the vaccine was shipped to, you're comparing apples and oranges if you try to do that division. So just want to be clear about that with our dashboard. We've also been asked questions about why the CDC dashboard numbers look different than our dashboard. CDC's dashboard is not meant to be a real-time tool. It is updated 3 times a week. There is more of a lag in terms of information getting onto the CDC dashboard. We are also learning about how the data transfer to CDC occurs. The numbers that you saw up there yesterday on that dashboard do not reflect all of the doses that have been administered in the state of Michigan. There are doses that have incomplete provider information that were not being included in that dashboard. So there are doses that have been administered appropriately by Michigan providers who had not fully completed enrollment in the federal COVID-19 program. And so therefore those doses were not getting counted on that dashboard. We've worked with CDC to identify this issue, and we've also worked with CDC to come up with a fix for this issue. So their dashboard will be updated. Today is Wednesday. It should be being updated today. And I think you'll see that those numbers have improved quite a bit. Next slide, please. Another way you can look at the COVID-19 vaccine doses administered, you can look at this by the type of vaccine as well as the provider facility type where the vaccine was provided. So if you're interested in understanding, well, you know, how many doses were administered by hospitals or by local health departments, this is the screen where you can see that information. That information is not yet provided by geography. Next slide, please. Another slide in the, or tab in the dashboard is looking at vaccine doses administered by sex and age group. As the data become more robust, we're looking to expand the information that's available on here so that different kinds of demographic information can be viewed by media and the general public. Next slide, please. There's also a graphic that depicts the number of vaccination program enrolled providers. Last week, we more than doubled the number of providers that were enrolled in the federal program. So we're up to now 845 COVID-19 vaccination program enrolled providers. You can also click on understanding what type of provider facility they are, what county there are, what local health department jurisdiction the provider is located in. Next slide, please. So I'm going to talk briefly about the B117 variant. We're in very early in our efforts to understand what this new variant means. And we're trying to share as much as we know at this time. What we know is based on the information we have currently and will change as new data emerges. And we're going to continue to provide updates about this variant as we learn more. Viruses change through mutation, and new variants of a virus are expected to occur over time. Many of these variants, do not spread because something about how the change in the virus makes it less able to replicate. There are multiple variants of the virus that causes COVID-19 that have been documented in the United States. Most of the variants do not change how the virus behaves. However, at this time, we don't have any evidence that infections caused by the B117 variant will cause more severe disease. But we do know that the variant that was identified in the UK has shown increased transmissibility. It's impacted the UK's steps that they've had to take to control the virus spread and will require stricter mitigation or stricter adherence to mitigation. We're going to talk a little bit about some mathematical modeling we did for Michigan that shows how much more severe the epidemic would have been if we'd had this variant in autumn. We get asked, what should we do about this variant? I think of it as this virus has kind of stepped up its game a bit in terms of its ability to transmit between people. Therefore, we need to step up our game in terms of wearing masks, keeping social distance and staying at least 6 feet apart from others, avoiding crowds, ventilating indoor spaces, and washing our hands often. So I'm going to take you through some of this detailed data, the best of my ability here. Next slide, please. So this graphic here is depicting the rolling 7-day average in the cases per million that the United Kingdom experienced. The gray bar is showing when they entered a national lockdown. So during the time of that lockdown, they saw their cases begin to decline, and then they loosened back up again. And then you can see they've had this very large resurgence in the number of cases, and more cases than they've experienced during the fall. Next slide, please. So the reason why they are experiencing this increase is because the number of individuals that a single person with COVID-19 infects has increased because of this variant. So this is meant to give you an idea of, so if you have a reproductive value for a COVID-19 case of 2, so each case of COVID-19 infects 2 other people, we can still have super spreader events where one person can infect many people. So you can get an idea of sort of the way COVID-19 can spread through a population. This B117 variant has a higher RT factor. Its RT is 1.5 times higher than other variants. So in this example, we're saying in this community, we get to an RT of 3 compared to 2. And you can see how many more people are impacted or infected by a single COVID-19 case. And again, because COVID-19 unfortunately does have the ability to be super spread, you can see how rapidly this variant of the virus can spread through a population. Next slide, please. There's a paper out by Voringer, and they were looking at the different RT levels that occurred for different types of viruses in the UK. So the 4 small graphics with the red and green colors on them are 4 different areas within the United Kingdom that were studied. Basically, they took, they sequenced samples from people with COVID-19, and then they calculated what the RT was for individuals who had, or for the population that had the COVID-19 B117 variant, which is in red. You can see the gray bar in each of these graphics is showing their lockdown. And you can see how the during the lockdown, the variant had a higher RT in most places than the usual strains of COVID-19. And then after that lockdown was lifted, how quickly the variant increased in terms of its RT value. Just for comparison, we're showing you the RT values for the state of Michigan at the top of this graphic. On November 11th, a line of 1 is saying that 1 person with COVID-19 only infects 1 other person. So November 11th, our RT value dropped below 1, which means that a person with COVID-19 is infecting less than 1 other person, which is a great way to bring the number of cases down in the community. Since then, we're beginning to see this RT value creep back up again. So this RT Live is a site that I'm going to keep going back to and looking at what the RT value means. Next slide about B117 is another way to get at understanding the sort of difference or how different this variant is in its transmissibility compared to other variants within the UK. And next slide, University of Michigan School of Public Health, they spent some time looking at a what-if scenario. So if the fall surge in Michigan had grown as if it was the B117 strain, the dashed line is showing you if we had 1.5 times the exponential growth that we did experience, what we would have looked like in Michigan. So this virus variant results in faster growth and higher case counts. What this means is that when you have a virus with increased transmissibility, we have to be monitoring the data very closely, but we also have to recognize that we need a faster response to increases that we see. And, I think the faster that we can get vaccine out and we can be providing people a measure of immunity to this virus, the better off we will be, particularly with the B11 variant coming around. Next slide, please. So you might be wondering, well, if you say we haven't seen the variant here in Michigan yet, how do we know that? Samples from genetic samples from people with COVID-19, genetic samples of the RNA in their virus, have been sequenced. The MDHHS Bureau of Laboratories has one of the strongest programs, public health programs in the in the nation in terms of advanced molecular diagnostics. And we were one of the first states to begin sequencing samples for COVID-19. So the lab will sequence any specimens that we test. The lab also works with local health department to identify individuals who they want to make sure that a sample from that individual is being sequenced. So right now we are working with local health departments. So if there's anybody who's positive for COVID-19 and has a recent travel history to the United Kingdom, that we're trying to get a sample from that individual and sequence that sample. Hospitals and regional laboratories also send unusual specimens, specimens that they are interested in having sequenced to our laboratory as well. Between MDHHS, University of Michigan, and other universities in the state, Michigan has contributed about 6% of all the sequencing done for COVID-19 in the nation. So we're going to continue to sequence our variants, and we'll be, as soon as we identify that the variant is in the state, we will of course be making an announcement about that. So I've got two last pieces of information. I know I'm running a little bit long here. I apologize. Just wanted to share a really brief update on mobility. So if I could go to the next slide. So we have been monitoring the percent of population who stays at home. The stay-at-home levels actually increased in November and have remained relatively high, including straight up through 12/26. And then my last slide I have are the Unicast mobility pattern data. The most recent data for Unicast, so this is looking at cell phone proximity data, has shown some return to, so 0 on these graphics is showing a baseline, a pre-COVID baseline. So for example, non-essential visits, the number of non-essential visits actually increased during December and January. All right, so this is data through December 31st, 2020, and it shows some return to increasing mobility. Right, so that is what I had to share. I hope that was helpful to you, and I hope it was understandable. I'm looking forward to a couple questions. Thanks.
Thank you, Dr. Line-Callow. This is Lynn again. Please raise your hand. You are going to be limited to one question. Like I said, we have a very short period of time. Brittany Flowers, please unmute yourself and ask your question.
Hi, can you hear me okay?
Yes, yes, we can.
Okay. Hi.
Sorry, Brittany, you have gotten muffled again. Can you try again?
Yes, can you hear me okay?
Now I can.
Sorry about that.
And now we can't.
Sorry, Brittany, you keep fading out.
Okay. Hi. How is it now?
That's better.
Okay, I'm sorry about that. Okay, just want to make sure I'm good. I know you addressed the COVID-19 dashboard in terms of how many vaccines have been distributed versus how many have been administered.
Sorry, Brittany, we're gonna have to move on. You keep fading out. Apologies. Please send me your question and we will work to get it answered after the presentation. Kim Russell, go ahead and unmute yourself and ask your question, please.
Yes, thank you. How far behind is the data lagging, do you think, from providers as we try to analyze and see where we stand with the vaccination administration rates?
So a COVID-19 vaccination that occurs in the state of Michigan should be reported to MICR within 24 hours. I do not have a figure for you about what percentage of those arrive within 6 hours or 14 hours or 28 hours. I don't have that number for you.
Okay, Robin Erb, go ahead and unmute yourself and please ask your question.
Oh, I'm sorry. Can I just add one other thing to that?
Oh, sorry, go ahead.
It's Quite a bit of our data comes in through electronic medical records and systems like that. So hospitals, for example, their data flow through automatically. So I want to be clear that they have 24 hours to submit that record, but very often, because of the investment in electronic medical records and health information exchange, that is able to come in relatively quickly. Sorry, Robin, to jump in.
Okay, thanks so much. Hey, would you talk a little more about the testing or sequencing for the new variant? I'm confused. You're not sequencing all of the test samples, but rather just those who have visited the United Kingdom? I was a little unclear on that. Could you clarify?
Oh, absolutely. So our state laboratory runs COVID-19 testing, diagnostic PCR testing. Any of those positive samples are sequenced. So if your sample is tested in our laboratory, we sequence that sample. Other samples are sent to our laboratory for sequencing. So if someone tests positive at a hospital or at a regional laboratory where and the local health department has identified that they have travel history, we'll attempt to get that sample or collect another sample from the individual for whole genome sequencing. So anything that comes through our lab for routine testing is sequenced. And then if we have specific interest in particular cases that our laboratory did not test, we will endeavor to get that sample as well for sequencing.
Okay, thanks so much.
You're welcome.
Great.
Hey, Will Callan, can you unmute yourself and ask your question?
Yeah, thank you. This is Will Callan with Michigan Radio. I was hoping you could speak a bit more about the antigen testing, and could you just tell us about how ideally antigen testing would fit into Michigan's kind of overall testing strategy?
Sure, I will do my best with that, and also check back with our testing team to make sure if there's anything that should be added to this, that we get that information to you. So the antigen testing, being a rapid response test, is a very important part of the toolkit. We provide antigen tests to local health departments so they can make use of them in response to outbreaks. There are many long-term care facilities that are making use of these tests as well, and urgent care. We've also begun a pilot with, it's a school sports pilot, to make use of antigen testing for rapid and frequent testing of athletes. So it is an important rapid response tool for many different kinds of uses within our overall testing strategy.
And is it paired in any cases with PCR testing if there's a positive test, say?
So this will, depend on whether you're being tested in a clinical setting or not. But it is useful if you have had a positive test on an antigen test, particularly if you're asymptomatic, to follow that up with a PCR test.
Thank you.
Thank you, Dr. Lancello. That's all the time we have today. I apologize. If you have any follow-up questions, feel free to send them to sutphinl1@michigan.gov. That's SUTFINL1, michigan.gov. Thank you very much for everybody who attended. I will be sending out the slides and a link to the presentation later today. Thank you.
Thank you.